Uh, it's really nice to see Dr. Rabia Zahid. How are you feeling now, Rabia, after passing the exam?
Yes, Assalamualaikum, sir.
How are you feeling after passing the exam?
Alhamdulillah, sir. Top of the world. बहुत अच्छी feeling है.
Okay.
और जैसे feeling पहले जिंदगी में कभी feel नहीं हुई. Alhamdulillah.
Okay. Try to speak in English, Rabia. And okay, so before we start, because we had a break because of my family commitments, and I was just thinking to restart from a easier topic for me to conduct. Okay, so we will be discussing some points about obstetric anesthesia. Usually, Rabia, I will ask you and Atiq, Dr. Atiq, to start with. What were the questions being asked in the current exam? Just highlight only the topics, just to take it out. What were asked, first of all, Rabia, and then Atiq, Dr. Atiq. What were the topic which was being asked from gynae ops in the Viva this time to you, Rabia?
Sir, the questions I remembered are the changes in anesthesia, and there were the pain management and
from obstetric anesthesia.
Yes, it was changes in anesthesia and another I forgot.
Like you mean to say the anesthesia special steps which you need to do if you are dealing with patient with like in obstetric patient, am I right?
Yes.
Okay.
Yes.
Okay, and Atiq, Dr. Atiq, would you like to tell what was the scenario or the question being asked from gynae ops to you?
Sir, actually, I didn't remember the rules. Sir, first of all, sir, assalamu alaikum, sir.
Walaikum.
Sir, I exactly couldn't remember the scenario, but the main the DD was two questions asked from me. One was from eclampsia, preeclampsia, eclampsia, and PIH definitions and all its anesthesia concerns, and the magnesium sulfate levels.
Okay.
And sir, the second one was amniotic fluid embolism.
Okay, so if just it was just to start our discussion. Actually, usually if you talk about obstetric anesthesia, first of all, it's very important because I don't think so any exam of anesthesia will be completed without a question from obstetric anesthesia. Okay, and usually if you just want to divide in two categories, so there will be an obstetric patient for any non-obstetric surgery. This will be one scenario. An obstetric patient for some obstetric procedure or any complication related to obstetrics, like ops scenarios. And third will be any medical disease in a pregnant patient. Usually these will be the three conditions, and the fourth one will be labor analgesia. Okay, so we will just try to figure out all these important scenarios. Okay. But to start with, what should be the first thing to learn? That will be the physiological and pharmacological and anatomical changes in pregnancy, which are modifying the anesthesia management. Okay, so we will just take a very simple scenario, and we will start from that, and we will go there on. That there is a pregnant patient who is 20 weeks pregnant. And now she is presented for appendicectomy. Okay, appendicectomy patient is having appendicitis. So you are being asked to conduct anesthesia. So just to start with, what will you be thinking? What are the challenges you will have when you are giving anesthesia to this patient? Jamil, would you like to say something? Who would like to answer this question? Dr. Atiq, would you like to tell?
The first concern would be the 20 weeks of pregnancy, sir.
Okay.
And my second concern would be the anatomical pharmacological changes due to pregnancy.
Okay.
And my third concern would be, sir, the fetal care, and sir, the fetal care, not to the abortion, sir, to prevention of the abortion. And my fourth concern would be the 2 lives, 1 baby and 1 mother. And my fourth person will be the risk of aspiration. And my fifth concern would be the type of anesthesia which I have to given, sir, and type of surgery, consultation with the surgeon, whether it is emergency or not emergency, sir.
Okay. So actually, first of all, this, yes, you're right.
Whether it is given, sir, it is given, sir, the laparoscopic surgery or the open surgery.
Yes. So like if you just broadly divide in this scenario, the challenges will be related to the altered physiological, pharmacological, and anatomical consideration in a pregnant patient. This will be one. Other will be that what could be the differential diagnosis of this appendicitis? Can it be something related to pregnancy?
Yes. It can be, sir, a rupture of ectopic and mecal diverticulum and ovarian cyst, and adreniform mold, sir.
Okay, very good. So like it will be, it can be something else. Okay, because appendicitis always have a differential diagnosis, and diagnosis of appendicitis usually, because I have put it 20 weeks, maybe they can tell you even early pregnancy, for example, in first trimester. Okay, so it can be even because what is the usual way to diagnose appendicitis? How do you diagnose appendicitis?
Through clinically, and sir, through ultrasound and through laboratory investigations, sir.
What laboratory investigations?
It's very unusual, but
can you be a little louder, Dr. Atik?
Sir, my sir, I will try, but my gala kharab hai sir mera.
Okay. So no problem. Actually, this is what I wanted to listen. Dr. Jamil mentioned it. Actually, usually the diagnosis is confirmed by CT scan. So in pregnant patient, you are unable to do CT scan. Okay, and even if you are dealing any other patient which is not pregnant, it can, like, they open it as a clinical diagnosis of appendicitis and it finds to something else. Okay, so this thing should be in your mind. And when they are dealing with appendicitis, if it is ruptured, the procedure will be converted to a bigger procedure than what is being anticipated. Okay, so because as an anesthetist, you have to keep these things in your mind, that it may be a ruptured appendix which can lead to peritonitis, and even if it has become appendicular mass, they may lead to hemicolectomy. So as an anesthetist, whenever you are dealing, you should be keeping this thing in your mind, that this can happen. Okay, and because of the other clinical features which the patient with appendicitis can have, if the patient is vomiting a lot, patient can have some electrolyte imbalance. Okay, and some of the features in pregnancy will be mixed, like WBC count is usually slightly on higher side in pregnant patient, and this can be a cause. Pregnant patient can have nausea, vomiting because of pregnancy itself, and it can be mixed with the appendicitis. So this is one challenge which you have to keep in your mind when you are dealing with this patient. So this is one thing. Okay, so of course you will have limited window for diagnosis, and sometime then you will be discussing. They can ask you in the same question, they can ask you the concerns in a pregnant patient related to laparoscopic surgery, because maybe it is it is better to do open or laparoscopic? Which is better?
So laparoscopic is better.
So is it your decision?
No, sir. It is the surgeon decision.
So don't comment on this thing that it is better or which is better. Okay, this can be a track. This can be a trap to you. So say that this is surgical decision, and of course morbidity is less in laparoscopic surgery. What thing will be different in a pregnant patient for laparoscopic surgery? What is difference from a normal patient to a pregnant patient? What is the difference?
Sir, couldn't get you, sir. Can you repeat?
Like, what is the difference if you are doing laparoscopic surgery in a pregnant patient than another patient?
Which is not pregnant.
You have to keep slightly lower pressures. Okay.
Sir, the pressure should be less than 8 to 10, sir.
Don't comment on this unless they ask you. Usually these pressure will be lesser than, I think I have read, if I'm not wrong, someone can correct me, I think it is 12 to 13. Rabia, can you just comment on it?
Sir, it should be less than 12. 8
Yes.
to 12.
Okay. Anyways, so this will be one point which you need to address. Okay. Then like we mentioned that there are altered physiological. Yes, Dr. Jasim, would you like to say something?
Yes. During laparoscopy, we have to consider the reduced functional residual capacity during pregnancy.
Okay.
And the abdominal insufflation may exaggerate this reduction.
Yes.
Therefore, we have to consider the pre-oxygenation and low pressure insufflation.
Yes, you are absolutely right. Actually, because the thing is that laparoscopic surgery, there are certain steps which are critical. One is the trocar insertion. The second is the pneumoperitoneal, like insufflation of the gas, and then third is the absorption of CO2 leading to the systemic effects. Okay, so these are actually, we will be discussing this thing in detail in some other setting, inshallah. So these are the things which are in any other patient. So the difference which I can chalk it out in a pregnant patient is usually the pressure, because if you are doing any surgery in a pregnant patient, so the effect will be exaggerated. Okay, because there is something already in the abdomen, and now which is already decreasing the pressures, which are already hampering the functional residual capacity, and now with the pneumoperitoneum it will increase. Okay, so the effects will be not 1 + 1, it will be 1 + 1 will be not be 2, it will be 3. Okay, so this is what the concept will be. Anything else, Dr. Jasim, you want to add?
Yes, during the pregnancy, and especially in second trimester onward, the changes in the upper airway edema need a consideration, especially during airway instrumentation, laryngoscopy, or even laryngeal mask insertion may lead to trauma to the airway.
Yes, you are absolutely right. Like if we just summarize the challenges to the anesthetist, is one of them is the difficult airway, not only because of the difficult laryngoscopy and as you mentioned, the airway edema, and risk of aspiration because of decreased gastric emptying and having increased residual volume in the stomach. Okay, so that will that patient is at risk of aspiration, and not only because of difficult airway and risk of aspiration. This is one challenge. Then there are certain changes in the dosage requirement of the medications which are being used. Can someone highlight what are those changes? Azhar, would you like to say, Dr. Azhar? What are those changes? Anyone else want to comment on this question? That what are the effects on the
Sir, the MAC would be decreased by 40%, sir.
MAC. Okay,
Sir,
MAC is reduced. Okay,
MAC
what
is
else?
reduced. Epidural would be, if there is 2 ml per segment, we will give, then it should be 1 ml per segment in a pregnant patient.
What is the reason for it?
Because of engorgement of veins, sir.
So because of increase in epidural pressure. Okay. Usually it is negative, but it is even increased, especially in the later half, because of the labor, when the patient is in labor. So it is even increasing even more. But before that, it is because of the engorgement of the veins and epidural pressure is increased. More chances of dural puncture if you are giving epidural. Okay. What else?
Sir, we think that's because of the increase the total body water, sir. Because of total body water.
Okay.
And then, sir, because of the increased cardiac output, sir.
No, what is the effect?
Oxygen consumption will be increased.
Okay.
And sir, because of the pregnancy changes, we will use the less doses as compared to the normal patients, sir.
Okay, can anyone elaborate it a little further? Like pharmacological changes in pregnancy. Anyone, please?
Yes, hemodilution during pregnancy and anemia.
Okay, physiological anemia. Okay. What about the effect of neuromuscular blockers?
That has got the same, sir, no changes in that.
They are sensitive to dexamethasone and sensitive also to neuromuscular. They need lower dose.
Sir, they are safe to in anesthesia. So non-neutralizing muscular blockers are safe in pregnant patients, sir. There is no harm to giving it.
No, actually we are not talking about safe or unsafe. We are talking about what is the change. So actually he is right, because of the reduced level of pseudocholinesterase, the effect theoretically can increase. Okay. But clinically the clinical effect is not too much appreciable. Okay. But actually because of decreased pseudocholinesterase activity, there can be chances of prolongation of effect of dexamethasone. Agreed or not agreed?
No, concentration,
Yes,
only concentration of cholinesterase decrease, but total amount is same, so will not prolong.
Yes, like clinical effect is not too much. Okay, so it's like that. So what about because of the can you please mute the mic, please? There is too much voice coming. Yes. Okay. So we talked about airway management. There is difficulty in management of airway, and we talked about reduced MAC. What about IV induction and inhalational induction? Naseem, can you mute the mic, please? Yes. What are the changes in inhalational induction and IV induction? What about the speed?
Yes, sir. Good evening, sir. Now I can speak because I switched to the mobile. if you allow me, sir, I can speak
Yes,
about inhalational. As we
Okay.
know that minute ventilation increase during the pregnancy,
Very
and
good.
there is
Just a second, Jamil, if you can just highlight more that minute ventilation is increased with the volume or with the rate.
due to tighter volume, due to the tighter volume, due to the increase of anterior posterior diameter of the chest, and respiratory rate increase, but not too much. Increase
Yes.
only the tighter volume.
Yes, fine. So this will increase the speed of induction or
Speed
slow down.
injection. Yeah. And this is the reason that there is a hypocapnia in the pregnant patient with increase of mechanical ventilation.
Recording आपने zoom कर दी?
Sorry.
Okay, please, I just a second. I humbly request all of you to mute the mic, okay? Because it is distracting everyone. Thank you. Yes, please, Jamil, repeat it. You know, inhalational induction. What about cardiac output? Because cardiac output is increased. Am I right?
Yeah. Yeah.
So what has the effect of increased cardiac output on inhalational
Also,
induction?
yeah, due to increase of the cardiac output, there is also increase the onset time for IV induction drugs. Means that IV to brain time is decreased instead of due to this rapid.
Just a second. I repeat my question. What is the effect of increased cardiac output on inhalational induction?
On inhalational ideally be decrease due to the increase of the cardiac output, but the patients have also increased the minute ventilation. That's why it's not rapidly increase the induction.
And another thing is that MAC requirement is decreased. Am I right?
Yeah, yeah.
So
due to progesterone centrally acting.
Actually, these effects
Sir,
are countered.
Sir, MAC are also decreased, and local anesthetics are also decreased because of the progesterone, sir.
Yeah, just try to focus on the question, Atik bhai.
Yeah.
So if we are only talking about the inhalation,
we are not talking about the local anesthetic. We're just talking about inhalation.
Okay, so these two effects are counteracting each other. Okay, this one is because of increased cardiac output. Whenever there is increased cardiac output, actually inhalational induction is slowed down. But here, the opposite things are more than this effect. So practically, clinically, because of the low MAC requirement and because of the increase in ventilation, actually the MAC is achieved earlier. Okay.
Yes, sir.
Okay. So you got it, Atik bhai?
Sir, yes, sir.
So what is the other effect of a slightly increase in ventilation? Whenever
there is hypocapnia due to the increase of mechanical ventilation, and it means.
So this is also clinical implication, because I am trying not to follow a specific pattern of the book. I'm just trying to correlate the effects clinically. Okay. So usually you will say that in the ABGs there will be slightly reduced PaCO2. So you have to maintain it. Okay. There will be slightly decrease in PaCO2. Okay.
Sir, one thing I want to say, sir, due to inhalation agent, it is important in non-obstetric cardiac surgery, surgery, sir. It is very important that halogenated vapors, halogenated agents cause uterine relaxation. That is beneficial for surgery during pregnancy.
Yes. So actually that will be, we will be talking, I will be talking something about the practical aspects, because sometimes theoretical aspects are opposite to the clinical, to the theoretical concepts. Okay. So practically what we have to do, we will discuss. You are absolutely right that inhalation agents are, especially at the patient who are at risk of going in PPH. Practically, we should try to reduce MAC as much as possible, or even if we have any doubt, we can convert it into TIVA for that time being. Okay, this is just something practical. Theoretically, they say that if it is less than 1 MAC, it has less effect, but actually practically you don't know exactly what is the MAC requirement for that patient in that scenario. Okay, so practically speaking, it's a very good idea that you switch off inhalational agents at the time just before delivery of the baby. So if you have any doubt of uterine relaxation, you can nullify this effect. Okay.
Yeah, and this is the reason that there is more chances of obstetric surgery. There is awareness during the obstetric surgery.
Yes. Okay. So this is one reason, is this one that you need to reduce the depth of anesthesia, and you because you can have obstetric hemorrhage unanticipated. Okay. So this is one of the reasons. Anyway,
there is another drug like nitrous oxide, sir, nitrous, and that should be avoided. It is a teratogenic, sir. It should be avoided in the even in third pregnancy as well, sir. And
no, I am not agree. I just nitrous is not culprit the whole in pregnancy. It's only contradicting it first 6 weeks. After 6 weeks, you can start the nitrous oxide until
organogenesis. Jamil, organogenesis occurs between which weeks?
If exactly say it's from day 31 to day 71. So but most of the books they say between until 8 weeks. Yes, until 8 weeks you better avoid. But if to exactly say, you have the organogenesis started from day 31 until day 37 from last
3 weeks to 5 months.
I'm sorry.
There's 3 weeks to 5 months the organogenesis period.
No, not 5 months. No, not at all. Not at all. It's in the first trimester.
Before 12 weeks.
In between 3 weeks to 8 weeks.
Yeah, this is more precious time where you have to avoid. But there is comprehensive. There is written that the organogenesis is started from. You have to avoid all these teratogenic drugs from day 31 until day 71 from the last menstrual day cycle.
Yes. So this is the reality of this thing, because actually nitrous oxide is a controversial medication. There are two group of people. Some people like nitrous oxide and some people don't like nitrous oxide. Similarly, there are two group of people. Some people who don't like succinylcholine and some people who don't use succinylcholine at all. So I am among the group who doesn't want to use succinylcholine at all and who always love to use nitrous oxide. Okay. So there are two group of people. So this is a total practical thing which you just be knowing that what is.
I just want to add that the nitrous oxide has among the volatile anesthetics, only the nitrous oxide has the minimum effect on the uterine tone. That's why it's not as bad as SIBO or halothane.
And another, this is one point, and another thing is that because the effect of drugs in pregnancy is not universally being done. Okay, so there is always not clear data. So majority of the drugs are not safe actually. Okay, or you can say they are undetermined. Similarly, for example, if you talk about compare between thiopentone and propofol, which is better for induction?
Sir, actually, all these drugs depends upon the condition of the patient. If patient is stable, then definitely propofol is better than the thiopentone. Because I say you the reason why this why, because thiopentone is more lipid soluble and has more fraction to the maternal fetal fraction. It can easily go through the placenta and accumulate in the fetus.
Okay.
And they have long act also. Onset of action means fraction in the fetal blood. But propofol comparatively, that one is more safer. Is
okay.
More.
Now you are stuck in some problem. Just tell me one thing. Just tell me one thing. What about the these drugs? How their clinical effects is subsided?
Yeah, no, but the other thing, the clinical side is like for
Both of
both
them
of them
are
is the
redistributed.
redistribution, both of them.
So redistribution. So this is one thing. I'm talking
Yeah.
in other aspect because they are at risk of
Hemodynamically stable.
and usually they have rapid. They require rapid sequence induction. So which drug is better for rapid sequence induction?
For with thiopentone is better because more lipid soluble, rapidly penetrate to brain, and
The terminology, the pinpoint word for it is something else. The pinpoint word for this is less brain arm to brain distance. Arm to brain time. Okay. So the shortest arm to brain circulation time required is for thiopentone. Okay. And propofol is not like have some teratogenic effects. That's why if you compare between thiopentone and propofol, thiopentone is preferred theoretically. Practically, we don't use, of course, thiopentone is now obsolete in majority part of the world, but actually you should be knowing this, at least the concept. Okay. Okay, so what about the neuromuscular blockers? The use of neuromuscular blockers, succinylcholine, we discussed that there is some reduction in the plasma cholinesterase, but clinically it is not a very significant effect. So this is one thing. And the other thing is that usually the effect of neuromuscular blockers are prolonged or no?
Non-depolarizing, they can prolong due to the progesterone effect, but depolarizing, like succinylcholine, they have clinically no prolongation.
Okay, so the usually we reduce the dose of neuromuscular blockers or no?
At induction, no, but the maintenance dose, yes, we have to reduce.
Okay, I'm talking about non-depolarizing, so it is only for maintenance actually, usually. Okay, so now some words about the airway management in a pregnant patient. So this is the same patient which we were discussing actually, the people who are this one. Okay, there is a question right now which is being asked that how to improve Abgar score of newborn keeping maternal safety during GA induction. So can someone ask? I repeat the question. Like here, the question is that how we can improve the Abgar of the baby when we are giving GA. Can someone highlight this thing? It's actually a very good question.
Sir, first of all,
okay. Yes, please.
Sir, first of all, we have to give the left lateral tilt. It's very important, whether it is GA or whether it is spinal,
okay.
just to improve the perfusion, sir, of the placenta.
What else?
Second is to avoid the opioids.
Okay.
Third is to the normothermia, normoxia, to the and sir normoglycemia, and sir mildly sir I would say normocarbia, and normovolemia to this patient especially, sir, because if you all keep these things and avoiding the acidosis, and sir if you are giving the opioids, then you have to prepare for naloxone to give naloxone, sir.
Okay, Rabia, can you just add some points to this question? This is actually a very good question. How to improve the Abgar score when you, as an anesthetist, when you are giving general anesthesia?
So again, these first of all maintain the position by keeping the wedge on the right.
Again, only tell the thing which Atik Bhai has not told.
Yes, maintaining the perfusion, maintaining the vitals, avoiding the roller coaster of the vitals, and avoiding excessive bleeding, and maintaining the normovolemia and normoxia is the other key points in this. But and also reducing the time of incident to delivery.
If there is hypotension before the delivery of the baby, which medication you should use?
Before the delivery of the baby. That is the phenylephrine.
Phenylephrine or ephedrine?
In a pregnant patient, ephedrine, and after that phenylephrine.
We are pinpoint at the time.
We have to use the seratimidate for especially using the for induction, and sir we have to give.
Atik bhai, please, Atik bhai, I don't agree with your answer. There is no need to dig your grave. What's the discussion of etomidate? We are discussing that if there is hypotension before the delivery of the baby, if you want to increase the blood pressure, would you like to give this one ephedrine or phenylephrine?
Sir, first of all,
ephedrine causes
bullous, and then sir, ephedrine, sir.
Just a second. Azishan, what do you like to say, please?
Sir, ephedrine causes fetal acidosis. So ephedrine should be avoided before the delivery of the baby.
No, I don't agree with you. I don't agree with you. Which decrease the this one, uterine blood flow. Which has more effect on...
Ephedrine does cause, I'm quite certain about it. I've read about it.
You are absolutely right, but we are talking about Abgar score. If does fetal acidosis has any clinical effect? What will happen?
Yes, to avoid the decrease in Abgar or in a patient already having low baby with fetal distress, then we should avoid phenylephrine and will give ephedrine.
You are absolutely right, Zishan. But if someone is asking you, you can say there is no clear-cut difference. So, this is causing fetal acidosis, but it is better to maintain the perfusion. So in that scenario, ephedrine is better than phenylephrine. This is my say. Maybe in some books you will find different answers. Okay, so you should have.
What is the effect of phenylephrine?
Phenylephrine is reducing the uterine blood flow. So phenylephrine is not a good choice in that regard. Okay,
it is other way. That is other way around, sir.
No. I am 100% sure about it. Phenylephrine reduces the... Yes, Rabia, please correct me if I'm wrong.
Sir, you are right. This is, I'm talking about something else that in pharmacological effects, we missed one thing that in reversal, we have to give neostigmine with atropine, but not glycopyrrolate.
Okay, no problem. We are, the topic at the moment is something else. What about the treatment of hypotension? Because now we have a conflict. Some people are saying that it is ephedrine, which is better, and some people are saying phenylephrine. There are more chances of bradyarrhythmias in pregnant patient when you are using phenylephrine. This is one thing, and the other thing is that the uterine blood flow is affected more by phenylephrine. Okay, ephedrine causes fetal acidosis, but it is not causing decrease in Abgar. You can read about it. Okay, and if I am wrong, please do correct me. If someone can Google it and share whatever is yes. Okay, so this is one thing. So now if we just talk about some words about airway management in a pregnant patient. Okay, so what are the problems and how you should manage? Like, what will be the problems and how will you tackle them? Like one of our colleagues told that there is edema. Okay, so you should be very careful in doing the laryngoscopy. This is one thing. Number two, there is problem with the FRC. So how you can improve the FRC? Yes,
sir, by giving the pre-oxygenation, sir. By giving
pre-oxygenation does not increase. Okay, fine. But answer is a little bit different. You have to make the...
You have to put the pillow on the shoulder, I mean, RAM position.
RAM position. What is RAM position? Rapid airway management position. You bring the external auditory meatus at the level of angle of Louis, the sternomental angle. Okay, so what will happen that actually you are not only easing your this one laryngoscopy, you are increasing a little bit of FRC. Okay, because head side is a little bit up, and now you are helping in even ventilation. Okay, so this is important thing. RAMP, rapid airway management position. Rapid airway management position, yes, in which you bring the external auditory meters at the level of sternomental angle. Yes, Dishan?
I've shared something on the anesthesia knowledge group. Can you see?
Okay, okay. If it is related to phenylephrine, we will just discuss.
Phenylephrine and ephrine.
So at the moment, anything else about this this thing? And what else we do to have an easier airway management?
Sir, we will use the small EDT tube, sir, just to not damage the because it is
smaller airway diameter.
7 diameter, yes, sir.
Okay.
And sir, we will you will reduce the time of induction, sir, just to time of laryngoscopy, just not to damage the edematous airway, sir.
Okay. What else? Pre-oxygenation, rapid airway management position. What else, which is actually part of something else, but you have to go do the acid prophylaxis. Okay.
Rapid sequence induction, sir.
Rapid sequence reduction or modified rapid sequence induction with rocuronium. Okay. This one, what is the critical volume which you should avoid for if you want to avoid aspiration?
Sir, 30 ml sodium citrate we will give.
No. What is the volume? How much?
It is 25 ml, sir.
25 ml, like you usually 0.25 to 5 ml per kg. Okay, and usually 25 ml. How much is the pH?
2.5, sir. Less than 2.5.
Okay, so
yes.
By now to tackle this thing, you have different ways. Okay, you have different ways. You can increase the gastric emptying by metoclopramide. You can give ranitidine or this omeprazole for neutralization. Omeprazole, and then the other thing is this non-particulate antacid. Okay, so these are the different ways to tackle this thing. RAM position and smaller size endotracheal tube. And what will be the different in airway management, like difficult airway society? This one.
It is ASA 3.
No. What is the difficult? For example, if you have failed intubation, what is the difference in the DAS protocol for pregnant patient? Can anyone highlight this thing? What is the difference in DAS protocol for pregnant patient than non-pregnant patient?
Sir, but I have idea that if on the first laryngoscopy, if your view is not good, and you can do the 2 maximum attempts by maintaining the position, changing the laryngoscope blade, and using a adjuvant with the one intubation like bougie. If you fail, you announce, you call for help and announce fail intubation. And in pregnant patient, there is risk of aspiration as compared to the non-pregnant and other patient. There we can use 3 attempts. But in pregnant patient, we can only use 2 attempts, and after 2 attempts, in pregnant patient, we cannot use supraglottic devices like LMA because there is risk of aspiration. But in
No.
non-pregnant patient,
No,
we
no,
can.
no, no. Just a second. Just a second.
No, sir.
No,
Sir.
you have to put supra. If you are failed after 2 attempts, you have to do. There are certain other factors which you have to consider. Is the urgency of the surgery? Okay, if there is fetal distress or no fetal distress. Okay, if you are able to, would you like to ventilate or no?
Yeah, but we can bag mass ventilation with in pregnant patient. If we failed, then we try to put the LMA.
What about what are you mentioning, Zishan?
Sir, there are 2 laryngoscopy attempts by the first performer, first doctor, and the third intubation attempt should be done by a senior colleague.
Okay,
After
fine.
that, we declare a failed intubation, we call for help and maintain oxygenation, and then supraglottic device can be used. Maximum 2 attempts.
Okay.
And then there is algorithm 3 for it, which is then the surgical airway.
Okay. What else?
When the supraglottic airway device is unsuccessful, at that moment we have to see if the surgery is essential to be proceeded right now, or you can wake up the patient and either schedule the surgery some other day or through another technique of anesthesia.
No, what about use of this one? What is called as no. I'm sorry. What about this
Face
one?
mask ventilation.
No. What about the other factors which you need to consider when you are managing airway for pregnant patient? Any other factor?
There are 2 things. Whenever we are attempting a second attempt for intubation, we always have
that you have done fine. But now whether you will be awaking the patient or proceeding with the surgery, there is difference in that. A little bit.
Sir, if there is emergency, of fetal distress, then we will have to go for supraglottic airway device, sir. If there is not, there is urgency, we will wait for, we will wake up the patient, sir.
What about use of this one? What about this use of
orally way?
No. Use of to converting to awakening the patient and going for regional.
Yes, sir. That is after the if the supraglottic airway device has also failed, then we have to see 2 things. Number 1, if we can wake up the patient and proceed with other type of anesthesia like regional, or we can plan the surgery for some other day.
Other day. This is we are talking about pregnant patient. Okay.
In pregnant patient, always we will put in mind that there is risk of aspiration.
Yes.
So in awakening the patient, we have we fail and we put the supraglottic device if safe to continue or awakening the patient.
Yes, awakening the patient. You are right, absolutely right. And if you are unable to ventilate even, what will you do?
If unable to ventilate, we will continue for the surgical airway.
Yes. Yes, needle cricotherapy. Okay. So this is actually, I was just searching. There is a table showing that what are the factors which will need to be considered. And yes, maternal condition, fetal condition. I will just show you. Just a second.
It's in the DAS guideline.
Yes. Okay. So these actually, I was searching this thing exactly to tell you the exact thing. Then maternal condition, fetal condition, level of anesthetist, opacity, surgical factors, aspiration risk. Okay, so this will be whether you are proceeding or whether you are awakening. Okay.
Sir, please can you share the previous slide where we can use the attempts about
Yes.
anticipating pregnant patients?
For that thing, he was right. 2 attempts and 3rd attempt by a senior, as Ishan mentioned. Okay. Okay.
So as consultant, you have to make 3 trial or what?
Yes, actually, this is, sometimes practically, doctor, we follow something differently. Okay. But if we just talk about theoretical, for pregnant patient, they say 2 attempts and then 3rd by the senior consultant, senior experienced doctor. Okay. In other, it is 3 plus 1. In non-pregnant patient. Okay. Yeah, you can see here they have maximum 2 intubation attempts, 3rd intubation attempt by experience. If they fail, you will declare failed intubation, and then you will try to maintain oxygenation, and you will try to put supraglottic. If you have put the supraglottic, you will see that surgery is urgent or no. If surgery is not urgent, you will awaken the patient. If it is surgery is urgent, you will proceed. Okay. And even here, you can try with the intubating element. You can try to intubate here with the intubating element. Okay. This is the same thing. And you have to discuss with the surgeon as well. Okay. So anything else? Anyone wants to share anything else about this point? Okay, so you are unable to maintain the airway and patient went into cardiac arrest. So what are the difference if in the management of cardiac arrest in a pregnant patient? What things you should remember?
Number 1, left displacement of uterus.
1. Number 2.
Number 2, the rest of CPR is almost same.
You will be pushing a little
after
higher
4
up.
of
A little high up. Okay.
a little higher up, yes.
High up you will be pushing, and what else?
And we have to plan for perimortem cesarean in 4 or 5 minutes. I'm not sure if it's 4 or 5.
Yes, 4th minute you have to do cesarean section on 5th minute. Okay. What else? Anything else?
Sir, only 30% CPR is effective as compared to the non-pregnant patient. The
Yes,
compressions.
that is actually data rather than management. Okay. So in management, you have to mention these things. In the similar fashion, I will ask you a terminology which is actually practical here at this point. What is intrauterine fetal resuscitation? Because the people who knows it will not tell. The people who have not discussed this topic with us, if anyone can answer, what is intrauterine fetal resuscitation? Okay, Jamil, please tell.
Sir, I have not too much idea, but I think patients should be try to maintain the vitals of the patient.
Okay.
And
intrauterine, what is what concept you are understanding? It is something you are doing from outside to maintain the pressure of the baby.
Usually in the
Okay?
placenta.
So
of the fetal.
the same thing, the same traditional favorite left uterine tilt,
Yes. Left.
oxygenation,
White
and
acidosis. Yes.
and if there is hypotension, you treat it. If there is this one if this oxytocin is going at a very high speed, you have to stop it. Okay, and that's it. This is, and you have to do the CTG. Okay.
Okay.
CTG and like discussion with the obstetrician for their further plan. So this is a terminology which they can ask you. And okay, so I will just try to finish the rest of the things.
Defibrillation.
I'm sorry.
Is there a place for defibrillation? Shock?
Shock for pregnant patient?
Yes.
I don't think so. There is any difference? I don't know. If anyone knows about, you can tell.
ACLS protocols are same. If there is a shockable rhythm, you have to shock.
Yes, like there is no difference.
I think it depends if the cardiac standstills or cardiac arrest is shockable or non-shockable.
Like there is no difference. Okay?
Yes.
Like, there is no difference or in a pregnant patient than other patient. Okay.
Because the fetus will not survive if the mother not survive.
Yes.
We have to serve the life of the mother to save the fetus as well.
Yes. Okay.
Sir, kindly you can repeat the fetal resuscitation intrauterine.
You tell, and we will discuss if anything is missed.
Sir, actually, we had a network breakdown there, and I couldn't hear that word. I only heard that there is no ACLS difference in resuscitation of the.
Okay, actually, in intrauterine fetal resuscitation, the concept you can say that you are trying to increase the perfusion of the baby from outside. Okay, so what thing you should be thinking that you will be doing the uterine left uterine tilt. Okay, if there is any high oxytocin is going on, you will be just trying to reduce it, and you can have some tocolysis. Okay, and if there is hypotension, you will correct it, you will give some fluid. Okay, and actually I found something I will share with in the group. It's there is a mnemonic for it. It's a spoilt. 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 S for syntocin on off. P for left uterine positioning with left uterine tilt. O for oxygen. Okay. I for IV with IV fluids. And L for low blood pressure. You treat the low blood pressure. And T for tocolysis. You give some tocolytic agent. Okay. So this is called as intrauterine fetal resuscitation. Okay.
Right, sir.
So because these are the things which we have to cover in a pregnant patient, we will try to go in as much detail as possible. Okay. So up till now, we have covered some of the physiological effects, some of the effect on the IV induction, inhalational induction. What about the hematological system? And what is the clinical effect of it? Hematological system. What about like RBCs? What about platelets? What about other things? There is dilutional anemia. Okay, because
RBC, there is an increase of RBCs, but comparatively increase of RBCs, there is more increase of plasma volume. That's why there is dilutional anemia, and there is also dilutional of all anticoagulant factors, but it will not clinically affect. Even opposite, it will be hypercoagulable state. And the third thing is Sometimes there is a decrease of number of platelets also sometimes, but it should not be less than 100,000. It's cause of gestational thrombocytopenia. And also, if we
What
say
about-
the von Willebrand disease type 1, it even improved during the pregnancy.
Yes. What about the coagulation factors?
I think all the coagulation factor increase except factor 5, and other one I remember, you know.
Can anyone tell which factors are decreased?
Sir, factor 2 only.
Factor 2 only? 2 is increased.
2 and 5, I think. 5 I know.
2 is decreased.
Factor 13, I think it will be.
Factor 2 only decreases, sir. 7, 8, 9, 10, 12, and 5 are all increased, sir.
Okay. And so what will be the effect of increased coagulation factor? There will be risk of thromboembolism. Okay.
Thromboembolism. That's why we give DVT prophylaxis, sir.
And what about the fibrinolytic activity? Is it increased or decreased or what?
Decreased.
Fibrinogen are also increased, sir.
Fibrinolytic activity is also increased. Okay. Fibrinolytic effect is also increased. Okay. So what else is left?
Sir, WBC also increased, sir, and so the platelets are decreased due to dilution only. That's the only difference. Yes.
Yes. Okay. And what about hemodynamic effect? There is decrease in cardiac output or increase in cardiac output.
So definitely there is increase of cardiac output due to the decrease in SVR due to progesterone. Also,
cardiac output. What is the relation between cardiac output and SVR?
Yeah,
sir,
definitely increase of
SVR is decreased because of nitric oxide, sir. And sir, there is also pulmonary vascular resistance also decreased because of
no. Just a second, please. Tell me why cardiac output is increased and how cardiac output is increased. Both of you are telling different stories. I'm asking you something else. You're replying something else.
Sir, SVR is inversely proportional to the cardiac output. As the SVR increase, it will definitely, oppose the stroke volume or cardiac output. If SVR decrease, it's easy to hard to pump out, and definitely it will increase.
Jamil, listen. You are telling very less.
I come into second thing, about the volume also, but the
Sir,
first,
preload is
if
increased.
you are asking the relation of SVR and cardiac output.
Jamil, just let me stop you and let me correct you.
Yeah,
I have asked you a very simple thing. You are telling me something which is, I'm not saying you are telling something wrong, but you are telling something which is not correct.
Different, yeah.
Which is totally different. I'm asking you something else. You are a cardiac output is measured by heart rate and
stroke volume.
So stroke volume.
There is increase
where is SVR here?
No. I indirectly I am telling that's why there is increase of blood volume, there is increase of stroke volume, there is increase of cardiac output. I'm indirectly telling that there is relation of SVR. Definitely we will not count in equation.
And what will be the effect of increased cardiac output? What can be there? What will be the changes in ECG?
ECG.
There can be displacement of the
there will be resting tachycardia
left ventricular, sir,
hypertrophy slightly. It's not.
Just a second. Sorry. Yes, Zishan, please tell.
The cardiac output is increased because the stroke volume is increased and heart rate is increased, along with blood volume is increased.
Okay.
So cumulatively, the cardiac output is increased.
Okay. So what will be the clinical? This is theoretical. Clinically, what will you find? You will find some murmurs. Okay, there can be ejection systolic murmur. There can be like heart can be dilated. There can be left axis deviation. Okay, so these are the things which you will be finding. Okay. What about blood pressure?
There is increase of systolic blood pressure 20 to 30%, and there is decrease of diastolic pressure, increase of pulse pressure.
No. You are telling wrong, Jamil. You are rusty today. This is not the effect.
There is a decrease of diastolic pressure, sir, due to a decrease of tone of the vascular tone.
And what about systolic?
Increase?
No.
10 to 20%, yes, sir.
No.
Huh?
Both will be decreased. Both will be
decreased. You are telling the change in elderly patient. Elderly patient is least likely to get pregnant. So you are mixing the elderly changes with pregnant. Okay. This is change in elderly patient. Okay. And there is another reason of blood pressure decrease. Now the favorite which you are talking since a long time, SVR. The decrease in SVR is leading to decrease in blood pressure and more effect on diastolic blood pressure than systolic blood pressure. Okay.
Okay, sir. Yeah, more effect on the diastolic pressure than systolic
okay
pressure. You
so
are right.
now this is like because there is physiological anemia, there is dilutional anemia, there is like increased cardiac output. So all of these are shifting this one oxygen hemoglobin dissociation curve to
right.
Okay, but we said that there is slight hypocapnia, so that will be effect opposite to it, or no?
Sir,
Yes, hypocapnia. They bring the shift to the left, hypercapnia to the right, because hypercapnia also offload the oxygen. And there should be increase of means the delivery of the oxygen to the tissue. There should be right side of the curve, because more offload the oxygen to the tissue during the pregnancy.
Yes. Okay. So you have
double Bohr effect,
and also there is decrease to 2-3 dBg as well, sir. Which
decrease or increase. Okay. This double. Yeah. What is Bohr effect? Bohr effect is the rightward shift. Okay. And double Bohr effect acts at the placenta.
Placenta level.
In the placental side, on the mother side, shift is covered toward the right, so that oxygen is delivered, and on the fetal side it is converted to the left, so it is increasing the uptake. Okay, so this is called
fetal hemoglobin.
Yes, so it is called as double Bohr effect. Okay. Okay, so a few other systems are left. What about renal? And what is the clinical interpretation?
There is increase of renal blood flow, increase of renal plasma flow, as eventually increase of GFR, and effect of this in decrease of creatinine level, more clearance.
So creatinine will be high?
Low. More clearance of creatinine.
Okay.
Serum creatinine will be low.
Yes, so creatinine will be slightly low, but it's not very like renal system is not very clinically significant. Anesthetic change is occurring. Okay, usually it's good that if it is more perfusion.
It is slightly of creatinine, it's the worrisome.
Metabolic alkalosis, right? Metabolic alkalosis in compensation due to loss of bicarbonate.
Loss of bicarbonate. How is it, Hassan?
Due to, sir, minute ventilation is increased, so in compensation, pregnant patients usually have bicarbonate in 19-20, around slightly less than normal.
Like you are saying that CO2 is decreased, so bicarb will increase. No.
No,
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 sir, bicarb is decreased.
no, no.
Bicarb is decreased. I'm sorry.
I
I'm
understood
sorry.
the concept.
Bicarb is decreased. Yes, you are right. You are absolutely right.
Bicarb will decrease, sir.
I heard increase. That's why I was confused. Okay. So what else? There is a effect of progesterone on the ligaments. So there is laxity in the ligaments. Okay. So that's why pregnant patient develops post-op backache, and this is she is thinking that it is because of the spinal, but actually it is because of the laxity of the ligaments, and there is post-op backache is because of that thing. And there is more chances of dura puncture because of reduction in the epidural space and increase of the epidural pressure. Okay. And what else we discuss about MAC? We discuss about decrease in requirement of local anesthetic.
I just want to add about this thing that before we have the concept that there is decrease of gastric emptying due to progesterone, but recently I read somewhere in comprehensive that there is no decrease in gastric emptying during the pregnancy. The risk of aspiration is due to the stomach position or increase of intra-abdominal pressure due to decrease of tone of esophageal physiological valve, but there is no gastric emptying.
Jamil, actually thing is that you may not be right, rather I will say you are right, but some things are because time tested, whatever is written in MCQs, if someone is trying to attempt this concept will not help. Okay. So
sir, excuse me, can I add?
Yes.
Can I add?
Yeah, actually, I correct the MCQs in.
I'm sorry, Jamil.
It is the labor time which delays the gastric emptying, not the pregnancy, sir. He is right.
Okay.
Actually, I did the MCQs and I got the answer wrong. Then I checked the explanation and he wrote that there is no gas delay in gastric emptying.
Okay. Okay. I'm not sure about it. If you
In comprehensive, chapter number 6 in obstetric anesthesia.
Okay. So we have just tried to, if any important clinical effect we have left. Rabia is here still, or she has gone? I think Rabia has gone. Anyways, anyone want to add anything clinical effect in a pregnant patient going for non-obstetric surgery? So there is risk of aspiration, there is difficult intubation, there is like you have to look for the decrease in FRC. Laparoscopic surgery will be more careful. You have to be careful in the pressures, and the exaggerated effect, like effect of pneumoperitoneum can be exaggerated. There can be hypoxemia, and the same things which need to be seen at the induction, the same thing you have to take care when you are extubating the patient. Okay. Yes, Dr. Jasem.
Yes, and I think finally we have to consider the post-operative analgesia. As there is a baby and there is a pregnant woman, and we have to select a reasonable analgesia for the pregnant patient in non-obstetric operations.
Sure. You are absolutely right. But actually, what about the contract? Like, yes, you have highlighted a very good point, which actually I had missed. So if you go one by one, paracetamol, you can give, no problem with paracetamol. Okay. What about NSAIDs? Can we use NSAIDs?
What?
NSAIDs. NSAIDs like diclofenac or ketorolac. Should we use?
They reduce prostaglandin, so avoided.
We should avoid it.
Non-steroidal anti-inflammatory drugs. If there is, we have to consider the premature closure of the patent ductus arteriosus.
Yes.
And this depends on the stage of a pregnancy, whether late pregnancy or early. If there is, if we are sure the it is closed, there is no risk of using non-steroidal anti-inflammatory drugs.
Okay.
Also, local analgesia, we can use local analgesia as infiltration or epidural. If
Yes. If you have, if it is open surgery, you can give stab block, you can give erector spiny block, you can give quadratus lumborum block, you can have like local infiltration. Okay, like there is no clear cut. You can use the ketamine infusion. You can use this one Presidex, like this dexmedetomidine. You can use lidocaine infusion. Like there is no clear cut contraindication. Okay.
And if we use opioid, we have to observe the mother for as there is risk of hypercapnia because of hypoventilation and the rigidity of the chest wall.
Yes, you are right. But actually, thing is that you can use short acting, and thing is that rigidity is on very high doses. Okay.
Yes.
So clinically, theoretically, you are right that opioids can cause chest wall rigidity, which can create some problem. And if there is a decreased level of consciousness in pregnant patient, it can have effect on the fetal circulation. Indirectly, baby can have some distress. So these are the things which you have to take care. And we have to, actually, we did not discuss this thing and how we have to conduct. So there are some administrative things you have to discuss with the surgeon. Sorry, you have to discuss with the obstetrician. There should be Ctg monitoring preoperatively, intraoperatively, and postoperatively. You have to counsel the baby, the patient, about the possible outcome and possible early abortion or early labor, early onset of labor. Okay, so these are the things. What about the fluids? Any difference in fluid management in a pregnant patient? Yes, Saqib, would you like to say something? Hassan, anyone? Yes, Hassan.
Sir, I would say,
please raise the hand and I will ask who wants to answer. Any specific consideration in fluid? Atiq bhai, you can tell, please.
Sir, there is nothing special in fluid, but sir, we have to be very meticulous about the especially in the pregnant patient. When we are giving it, it should be judicious fluid, not overwell fluid. But if we are giving spinal or then we have to give bolus and 200. And if
what is the reason? You are right. You are right. What is the reason of giving goal-directed fluid therapy?
Just to avoid the hypoperfusion of the placenta, sir, and the
no, it's not like that. Patient is already fluid overloaded. Okay, the volume is low. We just discussed there is increase in cardiac output, there is increase in blood volume. So patient is already on hyperloaded. There are flow murmurs are going on. So if whenever you are giving fluid, so you have to be you can use the word you have to consider this thing. Okay. And because just after delivery, the cardiac output will even increase for some times. That's why oxytocin should always be given with care. Okay, when we are using it for cesarean section. So these are the things which you have to consider. Okay, so I think we will stop at this point of time, and we will continue from here. Anyone wants to ask any question about it?
Sir, kindly I want to ask, we were asked a question that a 5 months pregnant lady, so she has to go appendicectomy. So why you will consider spinal or GA? What is your justification for that? So is there any specific guideline for that?
Just tell me one thing. If they are doing laparoscopically, can you do with the spinal?
No, sir.
Okay, if they are doing open, even then, you have to discuss with the surgeon, and this may be needing, like actually, you know, there is no difference. You have to achieve the goals. You have to maintain the perfusion. Okay.
Sir.
So there are chances of patient going in hypotension. So that's the reason. There are more chances of if they are using epidural, there are more chances of dura puncture. So they usually how many people do appendicectomy in spinal? Can be done, but is it? Why are we not doing it actually?
Sir, we are not doing it, but examiner asked that why will you not use, as you will avoid all the harmful drugs to the fetus, and premature labor is avoided. So why will you not choose spinal over GA?
A possible explanation can be that there are more chances of hypotension. Okay.
Sir.
And sudden hypotension can occur, so which can decrease the fetal fluid, like fetal perfusion. And another thing is that appendicectomy can be, if they are doing it laparoscopically, then we cannot use spinal. Okay. And sometimes if like from where I started the discussion, the diagnosis can be obscured. Okay. So sometimes you are not sure, maybe if you start with spinal, still you need to convert it to general anesthesia. Another thing which I have missed, and it should be the first thing. Are you securing the airway?
No, sir.
Pregnant patient is at risk. Okay. So if you are doing something in which there are more chances, like a normal pregnant patient can have chances of aspiration or risk of aspiration, and here you are having something which is related to gut, so there will be even more chances. Okay. So because your airway is not secured, so you can say straight away that I am concerned about the airway. So that's why I prefer to secure the airway with the endotracheal tube. Okay.
Right.
So you can say that it's not haram. Okay. It's not like contraindicated. Yes, Dr. Liana, you want to say something?
Assalamu alaikum. It's my daughter's name, huh? I'm not. Dr. Umar is here. How are you, sir?
Alhamdulillah. Yes.
Okay, so the thing is that one of the thing which is about the surgical approach we should consider also about the laparoscopic versus open one, because if it is the tummy is too big, he just told that it is the second trimester, so the most likely the uterus is not full term, so can be the laparoscopic approach can be there, but if it is the third trimester, it can be a little bit tricky to reach the appendix due to the gravid uterus. So we have to consider that point always, that like about the experience of the surgeon also by doing the laparoscopic approach, whether they are good enough to do, because if they are going to rupture the uterus, that's going to be catastrophic there inside the theater, which is going to the head, on the head of the anesthesia. So that's why it is even and the GA is not contraindicated for a pregnant lady. So it is we should go, but it is a safe approach. So in that case also, if they are saying that the spinal, why we have to give, it is not like the compulsory to give spinal. We can give GA, but we have to just do all the ticks there to monitor, to provide the safe anesthesia to the patient.
Yes. Umar, I would like all of you to be introduced to my dear friend, my buddy, Umar Mushtaq. He is in Qatar. And he is, because I invited him, and I think he joined a little late. Am I right, Umar? You just joined.
Yeah, because I got the patient.
Sure. So he has done obstetric anesthesia fellowship in Qatar. So you are still in Qatar, or you have?
Still.
Okay. So you know the thing which we discussed today was some of the physiological changes in pregnancy with relation to the laparoscopic surgery in a pregnant patient. Okay. That we just try to cover. So if you want to say a few words before we finish.
Miss most of that, just only laparoscopic, which I heard that one, but this patient, he just mentioned second trimester. In that one, maybe the laparoscopic definitely good option. But Third trimester, if they are saying it, so then you need to just first thing is that about this one, the surgical approach, and definitely you will go for GA. There is no other way. Other thing is that about the CTG monitoring during the surgery. That's very important. Another thing is that because mostly this will be done in that kind of setup, there is no obstetrician is available around. So you have to inform the obstetrician during the surgery. They should be available because they are at risk of preterm labor. So they can go at any time. We need midwife to deliver the baby because the other nurses are not comfortable in the baby. Other thing, then we have to inform the pediatrician also, because if it is a preterm labor, it is if like 26, 27, 28th week, baby comes out, then we need experienced hand on that from the pediatrician side. We have to tell them that also we are giving the narcotics to the patient. So if we are giving narcotics to the patient, it means that they have to prepare naloxone to reverse it, because it's going to affect the baby. This one I heard that you are just telling them about opioid effect on the babies. Other thing is that about the usage of that NSAIDs is not a good idea because of this PDA is there. I'm quite long time I did not read properly, but this NSAIDs use can be harmful for the babies because it can cause a closure. So we have to be careful for them. Other thing is that we should not be worried about the teratogenic effect of the different drugs. Our drug, we don't know exactly, because usually the question you will get from the mother is that how it is going to affect my baby if I will go for general anesthesia. So we don't know exactly, honestly speaking. We don't know that how. We don't have any study available to tell us that what is about propofol and all that. Only a little bit is midazolam and ketamine. We have it, a little bit evidence on animal studies, but not on human trials. So we can't give them properly this answer. Another thing is that about the reversal, neostigmine, and we are giving neostigmine and glycopyrrolate usually for reversal of anesthesia. So neostigmine can cross, but glycopyrrolate does not cross. If I'm wrong, just correct me, because long time I did not do that one, but I think so that can cause the fetal bradycardia. So we have to be very careful when we are using these reversal. So it can cause these things. I think so we covered all of that. If you guys want to ask, we can ask for this non-obstetric. This is a very important question. It's usually asked, and appendicitis is the most common reason to bring them here in the theater.
Yes. Actually, I said I wasn't sure. And opioids, you see, if you have to compare between risk versus benefit, because if you have a patient which has some cardiac problem in pregnancy, you have to give opioids. You will not say that this patient is pregnant, this patient has a baby, and the baby will receive opioids. So you should not give opioid and let the mother die of severe cardiac stress. So you have to give opioids, and then the neonatologist can manage it. Am I right, Umar?
Yeah, right. And we should them, and especially not only cardiac, definitely totally agreed with you. And another condition is that which is more common, cardiac cases, which maybe you will get very rarely, but which one is the preeclamptic patient.
Of course, fine.
This is 7%. Everyone is getting in one shift. It is very common because of obesity. Now it is becoming more common, and in that case you have to give general anesthesia. Do not hesitate to give opioid for induction. You know why? Because laryngoscopy is going to create a lot of already high blood pressure. With laryngoscopy, it can shoot up and it can cause intracranial bleed. Why we are worried about blood pressure in preeclamptic patients? Because their body is not ready for a high surge of blood pressure. You can see old people coming to emergency with 220 by 140 and nobody cares about them. But for us, 150 by 90 is their risk of intracranial bleed or for any seizures. Okay, so what is that one? So that's why do not hesitate to use even for induction. for PET patient also, you just inform the pediatrician to tell him that, okay, we gave the narcotics, we gave opiates, you have to manage it. And another option is that, which is available in many countries now, remifentanil. You can use remifentanil. It's very fast and it's not going to affect the baby a lot. So you can use 1.5 microgram per kg. So like 70 kg mother, so 100 mic you can use as a bolus, and you can. There's a very good articles on that. I will share on the group also to about the dosage of remifentanil for induction of anesthesia in pregnancy.
Yes, thanks a lot, everyone. Omar, thanks a lot. I will catch you if you are free tomorrow. We will be finishing in 3-4 days this obstetric anesthesia. So if you are able to get some time, I will be very thankful. Okay, everybody, thanks a lot for your presence.
Sorry, I have one question, sorry.
Yes, please, sure.
If the surgeon decided to do appendectomy with the spinal, with open appendectomy, what's the first anesthetic approach? Spinal anesthesia, epidural, or GA?
Yes, Umar, I will hand over this question to you.
So it depends on the stage of that one. If there is no like spinal, the thing is that you can do, as Dr. Zishan told earlier, that, but how much time we are doing it for the regular patient. So that's what I'm telling that one. There is no harm at all in giving general anesthesia to the mother. So technically, because of the stretch, because of the stretch which she's going to have on the peritoneum, and other thing is that about the stress which is going through, so to the mother to handle it during that one. So we should have square airway. So I will prefer to go for general anesthesia in that patient with the involvement of a pediatrician, obstetrician, midwives, and Ctg monitoring. There is no harm in giving GA to the patient.
Yes, actually, I will add on to few words to this thing, same comment which you did, because for we are giving for cesarean section spinal because of many other reasons, okay? But we are not giving it for laparotomy. Theoretically, if you are needing it T4, we can give spinal for every patient. But if you are trying to achieve the level of T4, there will be more chances of patient getting in hypotension, okay? So, and a stretch of peritoneum, patient will be uncomfortable, patient is at risk of aspiration, airway should be secured. If you are giving some sedation, then it will make your life complicated. And the surgery may be prolonged because of the obscure diagnosis, which is more common in pregnant patient than any other patient. Am I right, Umar? So these all reasons will give you vote against use of regional and favor general anesthesia, which will give you more secured life. Okay?
Yeah. Because I did whatever, like all the time I'm doing for the general anesthesia for that one. And then because of the more popularity of laparoscopic approach to there, so it's always then you have to go for general anesthesia if you are going there, because they are not going to tolerate it. I know that some case reports are there. You can still do spinal for laparoscopic approach, for laparoscopic cholecystectomy and appendix. But the thing is that, again, it is that there is some other reasons to go for that one. But if you will go for this kind of patient, pregnant, 5-month pregnant, going for surgery for appendectomy, so your options are there: spinal or combined spinal epidural. Epidural definitely not alone. It should be combined spinal epidural. And other thing is that general anesthesia. But I will go for general anesthesia definitely. In anesthesia, there is no right or wrong. The only thing is that how you can provide the safe anesthesia and what is good for the patient in that circumstances. So we can't say that we can't give spinal or we can't give general anesthesia, but if you will say what is safe in that patient, the most safe is going to be general anesthesia.
Okay. Any other questions? Okay, Umar, thanks a lot. Thanks everyone for joining. I will send the recording on the YouTube channel and we will resume tomorrow. Okay. Thank you very much. Bye-bye.
Bye-bye.